Hi everyone. So my case study is about a sickle cell patient who has hemolytic anemia, cold agglutinin disease, and eventually transfusion reactions. So we're going to go over a lot of topics today regarding all of these. So let's jump right into the objectives. After reading this with 70% accuracy, you should be able to recognize and recall the signs and common symptoms of sickle cell, describe testing used to diagnose sickle cell trait versus disease, associate a patient's history of transfusions, medications, and diseases to transfusion reactions. Also, given patient information, select appropriate donor units for transfusion, and also be able to calculate the amount of units needed to be tested for antigen frequency for required amount of units to be transfused. So a little background information on his admission. So a 30-year-old male, known history of sickle cell anemia, presented to the emergency room on January 18th in sickle cell pain crisis. So he complained of increasing pain in his back, hips, and chest. It had been increasing over the past few days. These are all signs of acute painful crisis and vaso-occlusive crisis. The patient should have hematology, chemistry, and microlabs run to check for his RBC count, his hemoglobin, hepatic function, and for underlying infections that could be due to his sickle cell disease complications, such as sepsis, pneumonia, or meningitis. He has not had a fever during this crisis, but has had poor response at home to over-the-counter medications, so he was admitted for pain control. A little bit about his known family history. His father had sickle cell disease while his mother had sickle trait. His brother also has sickle cell disease. His two sisters have sickle cell trait, and his other sister has sickle cell disease. So a little bit about testing for sickle cell. One way it can be done is hemoglobin electrophoresis via HPLC. So this is done over at HUP. It is the separation of hemoglobin species accomplished through the use of a gradient between two mobile phases with differences in salt concentration and pH. The rate of migration of each species is determined by such physical characteristics as surface charge, as well as the presence of hydrophilic and hydrophobic groups. So over on the left is a normal adult hemoglobin pattern. So you have mostly hemoglobin A, a little bit of A2. For a baby, it would be mostly hemoglobin F. Sickle cell disease shows no A and a lot of hemoglobin S. They can also have hemoglobin F, which is basically compensating for the lack of hemoglobin A. Sickle cell trait will have hemoglobin S and hemoglobin A. So his initial blood work upon admission, his chemistry results were all normal, but his CBC showed a lot of out of range problems here. So he had a very high white count and a very low red blood cell count. His hemoglobin was also low, along with his hematocrit. His RDW was very high, and this tells us that he probably has a lot of new RBCs, causing them to be very large, along with the sickle cells, which tend to be smaller. So his blood picture included hypochromia, polychromasia, microcytes, macrocytes, target cells, sickle cells, Hal-Jolly bodies, ascenocytes, and giant platelets. Target cells and sickle cells are obviously one of the main things you're going to see in sickle cell crisis. So here are some pictures of the initial blood work. Cell number 1 is showing polychromasia. Cell number 2 are sickle cells. Cell number 3 are target cells. And number 4 is showing Hal-Jolly bodies. So to start with some lab testing, we'll start with blood bank. A tube test method was used to identify his blood type. As you can see in the picture, the anti-B and the A1 cells came back negative, and the anti-A and B cells pelleted, as well as the anti-D. So this goes ahead and tells us that he is an A positive individual. He also had an antibody screen done, which came back positive, and his DAT was negative. Upon doing an antibody panel, he was found to have an anti-K and an inconclusive. Due to the inconclusive, a sample was sent to the New York Blood Center for further evaluations and antibody identification. Based on the anti-K found in his serum, we can calculate how many units will need to be cross-matched to find a compatible unit. K antigen is found in about 9% of donors. So to calculate for 1 unit, we need to take how many donors will not have the K antigen. So we're going to use the need of 1 unit. So we'll put 1 unit divided by the frequency of no antigen, which would be 91%, and that will give us 1.1. So from here, we'll round up to 2, and we'll test 2 units to find a compatible one. But since this patient is a sickle cell patient, he should be receiving big E negative and big C negative. So respectively, their frequencies are 29% and 68%. At this point, we would do 1 unit divided by 91% times 71% times 32%. This would give us 4.8, so we'll round up to 5 units to test. So to continue with the lab testing through blood bank, the New York Blood Center found many antibodies. These included an anti-M and an anti-IH at room temperature, PEG, and LIS. An anti-K at PEG and LIS, and also an anti-S and in cold auto. Their suggestion was to give K negative, M negative, big S negative, A positive units to the patient. Just to note, anti-DOA and anti-E were found later at a different hospital. Moving on to his transfusions. So the patient typed A pos and was originally transfused with O negative blood. After the recommendation from the New York Blood Center, he was transfused with A positive blood. This was due to his anti-IH. The reason that we are no longer giving O is because O has the greatest amount of H on the cell. So this would obviously cause him to have transfusion reactions. So to limit this, we are now giving A units. The reason group O is rich in H antigens is due to the lack of A or B genes converting these H antigens to A or B antigens. So moving on to his hematology lab testing, his RBC count continued to decline during his visit. So the stars in the graphs represent when he was transfused. The red star indicates he was transfused twice that day. So you can see after each transfusion, while it may have helped a little bit, he ended up continuing to decline between his red cell count and his hemoglobin. So at this point, they decided that it was best to stop transfusions. So moving on to more laboratory testing, we're going to go over a little bit of the molecular pathology testing. So the patient has an anti-I that was discovered by the New York Blood Center. So to see how he developed this anti-I, he was tested for EBV or mono. Mono is known to cause development of an antibody towards big I. So the patient's double-stranded DNA test came back inconclusive, but his mono screen came back positive, which can be an indication that this cold agglutinin anti-I could be due to this infection. He was also tested for parvo B19 and was found negative. Parvo B19 is known to attack P antigens on the RBCs, so my assumption of testing for this was to ensure that his hemolysis was not also due to this. So at this point, the patient was discharged. It was decided it was best not to transfuse him any longer, as it was not helping him, and if anything, it was making his condition worse. So he was sent home to rest and to manage his pain while he was still stable. So while this may seem like the end, it's not. There's a whole lot more. So after his discharge, he passed out on his way home and was admitted to Frankfurt Hospital. There he was transfused with 5 O-neg RBC units. They were unaware of how O-neg units affected the patient, so he continued to hemolyze these RBCs and showed a decline in his health after each new transfusion. Before being transferred to Jefferson, he was transfused with 3 more units, and then at Jefferson is where they identified those 2 new antibodies. While admitted, physicians realized that transfusions were obviously not helping, so they started him on steroids and an IVIG, and eventually switched him to Rituxan. He also began spiking fevers, so testing was sent to micro, and that revealed MSSA bacteremia. The doctors are assuming that this came from an infection in his hip, but at the time they decided not to aspirate the hip as the risk was not, as he was improving in all of his symptoms, and they did not believe the risk was worth finding out more information as he was already placed on antibiotics and they seemed to be working. As mentioned previously, bacteremia and sepsis are common complications associated with sickle cell disease. But wait, there's more. The patient was readmitted almost a month later due to fever, palpitations, and dyspnea. He also had positive systemic inflammatory response syndrome, or SIRS. Due to the time of his admission and all of his symptoms, he was swabbed for COVID-19 and influenza. At the time of his discharge, his SARS-CoV-2 was still pending. Since it was pending, they informed him to self-quarantine for 2 weeks just in case he did come back positive. So during this admission, he was diagnosed with bilateral brachial vein thrombosis. The doctors decided not to start anticoagulants due to his severe anemia, as the risks outweighed the benefits. So during his stay, the patient ended up testing positive for influenza B, and he came back negative for COVID-19. So that is basically everything on this case up to this point. It is still ongoing and will continue as he is a sickle cell patient. So it is quite often that he will be returning to the hospital due to his symptoms. So on to my questions. Question 1, which blood picture would indicate sickle cell anemia? And question 2, a patient with this hemoglobin electrophoresis can be diagnosed as A, a normal adult, B, sickle cell trait, C, sickle cell disease, or D, normal newborn. So just to do a quick summary, because that was a whole lot, this was a male that had sickle cell disease, came to the ED with sickle cell pain, so obviously he was in crisis. He was given transfusions. Those were not helpful because he had so many antibodies. He just kept hemolyzing all of the units that they were giving him. He also tested positive for mono and eventually developed MSSA bacteremia. At present, he is home and healing and doing much better. And these are my references. Thanks for listening to my talk. Hope to see you guys all soon.